I saw a patient, a 28-year-old, fairly healthy-looking woman, but she complained about recurrent urinary infection. And as you know, that is not uncommon in young women, but mainly we face it in a phase where they start their sexual life. Then they often come with recurrent urinary tractions. She, however, had a long history. She had already a long-standing boyfriend, so that was excluded, and she had been with gynecologists, and they had tried to treat it, and again she had recurrent urinary tract infections. And so if you ask her exactly how the voiding is, she said, sometimes I have a little bit problems initiating voiding, and that is very uncommon in young women. And you hear that in elderly men, but not in young women. She says that she voids 6 to 8 times a day. Seems a little bit more, but not so much. No nocturia, and she had no signs of incontinence. So, and then of course we asked what else kind of problems had, and she said, you know, my walking and my sports, I really am compromised, and you couldn't see it if you don't really look, but she had a slightly ataxic walking, and she felt a sensory dysfunction at the left leg, and she felt sometimes a little bit dizzy, so that a neurologist had already said, you know, we need to do a further checkup if you don't suffer from MS. Medication, she has no medications, but of course, to treat her recurrent urinary tract infections, she had all kinds of antibiotics with no success. But otherwise, she had no previous illnesses, and she hadn't born any children yet. So may I ask to the crowd, and what kind of diagnostics besides anamnesis would you now start? Or should I continue and then we'll discuss it all the way along? What do you think, Abhinav? They can also write suggestions in the chat.
Yeah, I am writing that only that to make this session interactive, they can write in the chat and ask whenever they want to ask.
Okay. But I think now yeah.
They were silent right now.
Yeah. Let's wait. You know, and it is a little bit uncommon case, and maybe that makes it more interesting.
Can I say something, please?
Sure.
Yeah, you're asking about the investigation. I would investigate by diagnostic cystoscopy and bladder biopsy.
Okay, that's interesting to start with cystoscopy and bladder biopsy. Would everybody do that like that? For whom is cystoscopy kind of the first thing to do in a very unclear case? In a 20-year-old, 28-year-old woman. What are you thinking about? You think maybe carcinoma in situ, or what are you thinking about? Or interstitial cystitis?
Yes, to exclude interstitial cystitis and or other inflammatory conditions, say Ehlers-Danlos or joint hypermobility.
That's very interesting. Anybody else who would start with that, or would other people start differently? Come on, it's not a next.
Yeah, I think better do a urine culture test and an ultrasound scan to assess the post-void residue.
Urine culture, of course, is very good, but she has been, this had been done, and yeah, you sometimes had, you found germs and they were treated adequately. So So,
Hello, good
think
evening.
we-
I would also do an MRI spine
you would do an MRI spine
and brain.
And brain. So,
Yes.
but when you're thinking of that, then you're thinking of following the you know, to get more clue if it's really an MS or not, right?
Yes, exactly. Exactly.
And that's totally right. But I'm a urologist, so the MR, the further neurological examinations was done by neurology, and I know that you're a neurology based crowd, but I'm a urologist, so of course I would also think she has to go back to the neurologist to check up, and we'll hear about that later. But I'm a urologist, so I think we should go to the next slide. Because my thinking is Abhinav wants more answers before he lets you see the next slide. Oh, there. So, as a urologist, you always think to do a vaginal examination first, because there must be, if there would be like a candida or something, you would also find it in the vagina. You want to see how the pelvic floor is, if, she says she has problems initiating the voiding. And we also do always a perineal and an intravaginal ultrasound, but she had a very small cystocele, and which is not uncommon even in young women, and so nothing really spectacular. We did, of course, a stress test in a lying and in a standing position, and that was negative. And we then, we are only urologists, but we can do the testing of the sacral reflexes. So, but we also didn't find anything. And all other reflexes, we are not as good as a neurologist, but also the neurologist hadn't described any pathological findings so far. Anal sphincter contraction is very important, as those who have been with us the last sessions know that the anal sphincter contraction is very much telling you if the peripheral and the lower motor neuron is intact. And of course, what we always do, and the order is now here not in a order I would do it. Probably I would start with a vaginal examination and then, of course, include a pelvic floor investigation. And there I found the first thing which made me a little bit think, because normally a young woman can contract her pelvis pretty, and she had only a very weak voluntary contraction. So, as a urologist, what do you think did we do next? And to make the story short, we didn't start with a cystoscopy. So if we didn't do a cystoscopy, even now, what would you do? Because, we have this functional problem. So what is the next thing we would do right away?
Uroflowmetry?
Yes, the uroflowmetry is definitely the next thing we would do. Can you go to the next slide? Yes. So is this a normal flow?
No.
No, it's could be a 70-year-old woman or a man, it's maximum flow is about 10 or so, I don't know, but 22, but it seems like, but then she has a dysenergic flow at all. And what's even worse, she has residual urine of 250 ml. So let's go to the next. Oh, wait a minute. What? Yeah. Now, of course, if we have a young woman with, it's not I know that urodynamics is my field of experts, and I'm always thinking of doing urodynamics. But if somebody with a suspected neurological disease and as a young woman has a dysenergic voiding and high residual urine, you definitely should refer them to a neuro-urologist to do urodynamics. I don't know how many of you have access to that, but that is something, if you want to know what kind of functional problem she has, or if she has a functional problem, then you have to do urodynamics. And only Abhinav, maybe you can show, the first line is the vesical pressure. The blue line. Yeah, the blue line. Yeah, okay. No. Go back. I first wanted to go to the basics of urodynamics again, to repeat it. This is a vesical line. Beneath is the abdominal line. So you have a catheter in the bladder, and you have the catheter in the abdomen. And when you subtract the abdominal pressure from the vesical pressure, then you have the detrusor pressure. And when you look at the whole curve, the detrusor pressure is low. There are no high pressures. The filling phase seems totally okay. But if you already look at the first sensation with 343 ml is rather late. And the first desire to void with 533 milliliters is definitely very late. You have to always remember she otherwise is a young woman. And 533 ml as a first desire to void is very low. So then we, of course, give her the permission to void, and then she voids. And you see kind of the same picture. And now you can go to the next slide. And now it's a little bit enlarged. You see the voiding. And the voiding is terrible for a young woman. And you see only a small flow in these red dots. And you also see the EMG that it is not really relaxed. It's relaxed in the beginning, but then it doesn't keep through. And also in the beginning, it seems that she has to use some abdominal pressure even, and there is very little detrusor pressure, or the detrusor pressure is rather high when you look in the vesical pressure, but the flow is horrible. So, and let's go to the next picture. So, as you might know, if you have a low flow and a fairly high detrusor pressure, that always speaks for an intravesical obstruction. Because if the detrusor itself would be the problem, then you would also have a low flow, but you would have little or no detrusor pressure. Let's go to the next one.
Yes, Dr. Abhay. Excuse me, Professor. Dr. Abhay wants
are
to
there
ask
questions?
something. Yeah, yes, it's important.
Oh, please explain the dysenergic voiding. Oh, I didn't see that. Yes, the dysenergic voiding, maybe you go back 2 slides. Yeah. So you basically, if you see the slow curve, it should be in a normal woman. If you void, it should be a truly bell curve. And this is not a bell curve. And this could have be because under this investigation, it's always worse than in real life. But we saw the free flow in the beginning, and that was also dysenergic. So that's what we call dysenergic. you know, or
Actually,
this.
I had one more question. What
Yes.
is the lower limit of pressure and detrusor pressure generated in women? Because females tend to void with relatively lower pressures than the males.
Very good question. Very good question. Which leads us right to the thinking. You are right. Especially if you see women with stress incontinence, you sometimes see no detrusor pressure. But and that's one of the key messages is to discuss the function of the bladder, you always have to put the flow, and maybe now you can move to the next slide so that I can explain it there. You always set the flow in relation to the pressure. Just think if you have a hose, you know, just a hose and you want to water your plants. And there's no, and the water out of the hose is just dripping. Then you know there can be two reasons. Either somebody is having the foot on the pump, on the hose, or you haven't twisted the crane sufficiently open, right? So if there is a low flow, there can be two reasons. Either the detrusor can't react right, there is no good contractility, or there is an intravesical obstruction. So, but this pressure is rather high for women, and there was a very good observation. Women with 39 centimeters of water and only a flow of 5 ml, that is something confusing. So let us show the next.
Actually, please wait. In this slide also, when the flow has started.
Wait. Let's go back. I love it when you ask all these questions. Yeah.
When the patient was asked to micturate, when the flow just happened, the detrusor pressure was just about to begin. But when the detrusor pressure reached its peak, the flow stopped. And there was also some kind of electrical activity in the EMG sphincter just before the flow starts.
Just before the flow starts, which shouldn't be. It should be relaxed.
Yes.
When the flow starts, and then it relaxes, but then soon the EMG kicks in again. And we call this like it's not a clear diagnosis, but this would be like a hint for a detrusor sphincter dyssynergia, if it's a neurogenic cause. And since we don't know yet if it is if it's a neurogenic cause, but we suspect that, we would call then it a detrusor sphincter dyscoordination. The detrusor sphincter dyscoordination you find in many kids with enuresis problems. They don't have a neurogenic. It's just the whole nervous system is not really ripe yet. So we then talk from detrusor sphincter dyscoordination. But in a patient with a neurogenic cause, you would talk of suspected detrusor sphincter dyssynergia. And
thank you.
And now we can go to the next slide. So, and you might have heard that there are different obstruction nomograms and different formulas, but basically they all describe the same. They describe that a high pressure, the high minimum pressure at the maximum flow, and a low flow rate speaks for an infravesical obstruction. And there are nomograms for men with suspected VPO, also mostly the prostate or a urethral structure. They are very much investigated. And unfortunately, there is no real nomogram existing for women. But the principle that a high pressure and a low flow speaks for an infravesical obstruction also is true for women. And there is this red dotted line, which is, you know, if a woman doesn't lie in the infravesical grade 1, or an OCO of 0.35, under 0. Then we can say she is most likely she has an infravesical obstruction, because otherwise we have no explanation for the high detrusor pressure. And so this patient has a far too high infravesical obstruction. Are there questions to this nomogram? I think for most of them, it's very new to see, right?
There is one question, Professor Ruth, in chat. I don't know.
Okay. Okay. So then we should move on, right?
There is one question in chat.
The subtraction isn't absolute equal. So the MDP might be slightly due to poor subtraction. What do you mean that is not absolute equal? The subtraction? No, I mean, you see the detrusor is differently. You always try to put the point of the lowest detrusor pressure correlating with the highest flow. So that's when you get this point. You can also have you can also have a graphical, but then it's more difficult to, a point is always more easy to deal with. Actually, it's more like a curve, and then to simplify it, we take this lowest, the lowest detrusor pressure at maximum flow. So if you have several points, you just look which is the lowest. Does this explain?
I think yes. So we should move next slide.
Okay, we should move on. And now comes the cystoscopy. And of course, if I do a cystoscopy, I also look for stones or for malignancy and everything else. But you know, everybody of us is in its own clime, and I'm just a functional urologist. So what I mainly want to do with my cystoscopy is to exclude an infravesical obstruction, organic infravesical obstruction, because there are cysts, there are urethral diverticular which cause this. So I want to make sure that there is no organic infravesical obstruction. And no sign of an infravesical obstruction. So it's a functional infravesical obstruction, which is, of course, a clear hint that there is an underlying neurological disease. We can go further. Now, of course, we could have also done that earlier. We'll after the uroflowmetry is not complete without checking for residual urine, and we saw that she has a lot of residual urine. And if you see, this is now an X-ray because we always do video urodynamics, so we have the X-ray parallel to the urodynamics. You see an overextended bladder, which is, of course, frustrating. Yeah. And maybe you see already also some irregularities at the bladder wall. I wouldn't over-exaggerate it, but it definitely looks overexpanded. And then, of course, if you do ultrasound of the bladder, we also do X-ray or ultrasound then on the kidneys. And next. But next. And as you see, it's not a lot, but there is some dilatation of the right renal pelvis. There is some. Sometimes you see that without any pathology. Oh, now I hear myself twice. Maybe you can, somebody has to mute themselves.
Okay. Ma'am, do you have a question?
Yeah, no. Yeah. Okay. Does she? Yeah.
Okay, I don't think. Do you have any question, ma'am? I don't think it.
Okay.
We can.
Okay. So, but of course, in this having an overextended bladder and having a detrusor sphincter dyssynergia, this even it's only and having all the recurrent infection, this is bothersome. So we do also next slide. Next slide. Yeah, so the left, oh, sorry, I will the left, go back again. The left slide didn't, so on the left side there was no, I would say no renal dilatation. It looks better than the right side. And this can happen normally if there is an infravesical obstruction, whether it's functional or organic, you see on both sides. But this is, you know, but if the bladder extends, it might very well only through the extension cause a renal dilatation of the pelvis, because the kidney now has to fight not against high pressure, but you know, it can't get in the urine so easily into the bladder. Next slide. And you see here again also the detrusor sphincter dyssynergia. So what do I do first? Now, if you have such a poor voiding, first-line therapy is catheter treatment. And you might think she has already recurrent urinary tract infection. Why teach her in a clean intermittent catheterization? I tell you, that is often the solution. The residual urine, if it's in the elderly a little bit and she has no problems, doesn't have to be treated. But in a young woman with recurrent urinary tract infection, you should introduce clean intermittent catheterization as soon as possible. And I know all non-urologists are, yes, Dr. Abe has a question.
I would like to know how to decide the frequency of CIC in this situation.
Okay, that's a good question. And we want the bladder not be overfilled more than 400 milliliters. So it really depends a little bit. And she can, of course, still try to spontaneously void. You should tell her not to use abdominal strength too much. And you have to kind of find out how often she has to catheterize without expanding the bladder more. Because if you extend the bladder, the detrusor will get worse and there will be morphological changes I don't want. So the amount of catheterization is dependent on symptoms and mainly not to overextend the bladder more than 400 ml. So, and there are a lot of varieties. We use non-reusable catheters, but I know that there are also reusable catheters on the market and still better than doing nothing. Next slide, I mean. Of course, you can also start behavioral and conservative approaches. Nothing wrong against telling her to go timed voiding. If she can void them without using a lot of straining, that's very good. You can also palpate her pelvic floor, and she could use a little bit her pelvic floor. You know, you remember her strength wasn't that much, but this is now about relaxation. So, and everybody who does Pilates or any kind of sports or yoga knows that contraction and relaxation is always kind of part of the same exercise. So if you can try her to use her pelvic floor more efficiently and try to efficiently relax her pelvic floor. If you have a trained physiotherapist who can do that. And if she doesn't want to overextend her bladder in the morning, because then you should limit the fluid intake in the evening. And you should avoid diuretics, of course, but that's more, and caffeine and alcohol, that's probably not her problem. That's more, these tips are better for the elderly. And luckily, she is not incontinent, so she doesn't need absorbent products. But you see already, behavioral treatment failed. And we even tried to do flow EMG, which means that you have a flow and you do the same time an EMG. And there are gimmicks that, you know, that the contraction of the pelvic floor is like dolphins jumping out of the water, and you have to try to make the dolphins swim, or other kind of gimmicks. So, but all these didn't help. Next slide.
Professor, there is one question on catheter.
Oh,
on the last slide in the chat.
Yes, it's also a very question. Her pressure bladders in the filling are not in any danger zone. That is totally true. But remember, her main complaint were the recurrent infections. I'm not so much worried about her kidney, although she shows a little dilatation. I'm much more concerned about her bladder, because you don't want to harm the bladder. But you are right, the pressures in the bladder are not in the danger zone, and that is a good thing. But she will worsen her bladder function, which now she can still cope on, but she will worsen her bladder function if she doesn't take care of her bladder. But that's also a very good remark. We think the bladder pressure is in danger. The kidneys are in danger, especially in spinal cord injured patients, when the pressure is over 40 or for a longer time, you know, always phasic detrusor overactivity, or a low compliance bladder over 20. So good question. I love if you ask questions, and I'm sorry if I don't see them right away. So next slide. So, and then we have us at the same question we had last time. We had a discussion, and I first didn't get the question about beta-phenol, not right, because I didn't understand it. It is historically used, and theoretically, that is has some benefit, and it is still around, and it might help in some patients with unknown cause of detrusor under contractility. But I'm now in the business for over 30 years, and it is no proven sufficient treatment. And if somebody mentioned you have to use very high, like double or triple the doses as recommended, and then it would work. Actually, then you also triple and double the side effects, and you have a young woman who has to live with it. And so in all clinicians I know, they don't use beta-phenol for detrusor underactivity any longer, because you only delay the time, because I think she has already problems, otherwise she wouldn't have recurrent urinary tract infection. You need a solution right away. It's no problem then also to start first. I don't like to use, because I've never seen any benefit, and I think medication should be only seen if you see a benefit. And if somebody proves me wrong, that's okay. So we didn't try. So what we did try, and that's also off-label, we tried, of course, to reduce bladder outlet resistance by alpha blocker, and that sometimes works. And there's nothing wrong if you try that when you already make sure she can do intermittent catheterization, because then you can monitor if the residual urine decreases. And again, some women who really learn how to relax their pelvic floor And then alpha blocker could be, and then she has tolerable residual urine. But unfortunately, in our woman, both it failed. And then, of course, I also don't use alpha blockers for a long time because it also has side effects and you don't want them in a young patient. And remember, she also complained, as many patients with MS do, with she complained of dizziness. And alpha blocker and dizziness, that's not a good combination. Next slide. So 6 months later, she's still on intermittent catheterization. My saying is the first 6 weeks they hate you and then they get used to it. And in those patients who have a lot of symptoms before, then they're really happy. But MS was confirmed, but surprisingly, she had a lesion above C7, which is not really what I would have suspected after her urodynamic bifida. But of course, the detrusor sphincter dyssynergia would very well go with a pyramidal tract above C7. You have to know that all the imaging we have still in the moment, maybe in 10 years at least, you can't directly conclude about the functional work of the bladder. That's why we have to do, in addition to imaging, also the functional testing of the bladder, because up to now, that is the only way to tell the neurological lower urinary tract dysfunction. And will you allow this lady to have spontaneous voids? Yes, I will, as long as her bladder capacity is not over 400, max 450. See, if you know the residual urine and what she voided, if that exceeds the 400 to 450 ml, I would tell her she has to increase this. But otherwise, I would allow it, and it makes it easier for the patient to accept. So I'm basically, for me, then I'm sometimes pragmatic and say, yeah, we'll try. So she has no neurogenic detrusor overactivity. So like most MS patients with this have, so she doesn't need any antimuscarinics, which is good because remember, patients with a neurogenic bladder dysfunction also have a neurogenic bowel dysfunction, and antimuscarinics are one of the main side effects are an obstipation. But the good thing is she is, we taught her well, because in the beginning, when you start intermittent catheterization, you can, of course, also have urinary tract infections. She has no urinary tract infections any longer, no more antibiotics needing, and she actually felt that her quality of life improved. Next slide. So the residual urine didn't change, unfortunately. Nothing helped. Nothing. Next time. But it looked a little bit more synergic, I would think. But the next time, next. At least we could see that the dilatation of the renal pelvis wasn't done. It was still, it was gone. She got rid of her overdilated bladder, which is good for the bladder health. And it will also, if you have an expanded bladder, then the way of the urethra through the bladder wall also gets longer. And so a healthy bladder is the best thing a kidney can wish for. Next slide. The sensoric has improved. She has now still a late sensoric, so she has to go, if we allow her to do spontaneous voiding, she has to go timed voiding. So she has to try to void before the bladder is dilated. But at least now she had a sensory urge already at 442 and not over 500. So that is a slight improvement. Next slide. No improvement in the micturition phase, which I basically see in the majority. Doesn't say that you shouldn't try pelvic floor and alpha blocker, but do it the same time you start with intermittent catheterization. And your goal is to improve the amount of allowing her to void spontaneously in between. They always kind of should try to do catheterization in the evening and in the early morning. So next slide. So MS, I say the Ken is probably wrong. MS always involves different areas in the central nervous systems, and that why the picture we see in the what it affects the lower urinary tract can be so different, and imaging alone is not sufficient. You need a thorough clinical evaluation, and you need also the reflex situation to see how much upper and lower motor neural lesions are involved. And urodynamics are the only tool to really diagnose the neurological bladder dysfunction. I don't say that every patient with MS needs a urodynamics right away. Although if you see some of my publications or Anke Jeckel's publication she did with me, we would kind of recommend to do early urodynamics. If you don't get along with your other treatments, I wouldn't wait too long for urodynamics. But maybe that is a biased advice. It's not in the guidelines yet. But there are some studies hinting for that. Next slide. What is the upper limit of the fluid in women after we use to be high pressure? Oh yeah, that's again a great question. Let me answer that first. I would, in the guidelines is 40 ml, 40 centimeters of water. But as I already told, it nearly takes 10 years for studies, or 5 to 10 years. I don't want to be pessimistic, to get recommendations found in studies into the guidelines. So the upper limit used to be 40. But nowadays, all urologists I know kind of agree it depends how often during the filling the bladder is over 20. And if it is often over 20, then I would be already start with medications. I wouldn't wait, because if you start early, you have much more, there's more effect. And now you can go to the, well, is this a question answered? It's not so much about the limits, the truther, if there is one higher pressure or if there is only an urgency to void and there is a detrusor only in the end of the filling, and that is over 20, I wouldn't worry. But if she has constantly pressures over 20, I would be worried. And 40 is a cutoff, is a guideline cutoff. Recommendations. I think maybe sacromodulation. It's not in the guidelines yet, but there are more and more studies saying that patients with MS, no matter if they have a detrusor overactivity or rather a non-directive bladder, might be a solution. And the modus, why it works and how it works, is still under investigation. And we always asked about research fields, so sacromodulation and intravesical stimulation, also tibial nerve stimulation, where you stimulate the sacral micturition arc by stimulation the nervus tibialis, can be, but it's still, I think it should be used in the context of clinical trials. But there are more and more good publications coming about trying sacral modulation, and I would favor to do sacral modulation to try it first, and then do the final exclusion. Kadir, do you have experience with sacral modulation in patients with MS?
Yes, actually, I have several patients, but I did sacral neuromodulation, some of them. One of them is a pediatrist. She's a doctor with MS. We did botulinum toxin injection at first, and then started with difficulty of voiding, and we try to insert the sacral neuromodulation in test 1, and we success. And she now more easily void now after the sacral neuromodulation, but very limited number of patients I have.
And it's all, and if you say it sounds that she still can't empty the bladder completely, right? Or it can do
almost
with
yes.
straining,
Yes.
Almost. Okay, so there is hope.
No need CIC now.
Yeah, because I think much more rigorous. I see when I'm also in pediatric, like in patients with spina bifida, we try to teach the mothers already to do intermittent catheterization as a newborn. But yeah, so we are but that is the safest option. But of course, you know, if you can, if you get acceptable voiding with sacral modulation, why not? And that has to be individually decided.
Yes, of course. For example, one of my patients with spina bifida occulta, adult patients, finished the clean intermittent catheterization after the sacral neuromodulation.
Okay, yeah, we have seen that too. We have, yeah, but there are rare cases, and they are still, you know, it should be in the hands of experts, and you have to closely monitor them. But I think that is something to look into, but it's not yet so that we can recommend it to everybody. You would agree?
Yes, I recommend the patients they should at least they should test one if we have a little bit relieve their symptoms, at least 50%, we can proceed to the test 2, but it is not even it is not a standard therapy. We should try in also neurogenic patients. I think so.
Yeah, I agree. We do have a lot of experience with sacral modulation, but we do it mostly for non-neurogenic patients, and the procedure is not too difficult, so it is something involved. But I think you have to be careful watching when you do it for neurogenic neurogenic lower urinary tract dysfunction, and you shouldn't do it if there is no detrusor action seen at all. No detrusor action, no modulation. That's something everybody agrees on. And then we do the next slide. Oh yeah, that's my favorite, because that's the two arenas with whom I visited Ukraine already 3 times, and I hope to visit Ukraine next time. Next slide. If Kadir, do you want to? Should I go on with spina bifida, or do you want to present a case?
Actually, I can present my cases. The first one in my case is also spina bifida. We can discuss together, I think so.
Yeah, no, sure.
Abhinav, I will screen share. I will share my screen now. Could you stop your screen share? Okay. Okay, now
We see it.
Yes, could you see my screen now?
2 thumbs up.
Okay. Okay. And now?
No, oh.
Yes.
Did I give permission for this photo? Yeah, no, I'm
Yes.
only.
We
No,
were,
thanks.
we were,
I remember. No, it's very nice, very nice. And this
Yes.
is Lilia, a Ukrainian doctor whom who made a internship with Thomas Kessler in Switzerland. No, thanks for this nice picture.
Yes, yes. We will have a project. We will try to find a sponsor and grant. I think within 1 month we will start. I hope. Okay.
Very good,
I
very good. So will you tell us about the project next
of
next
course.
week?
Uh-huh.
Okay, so I'm very, yeah.
We can continue with my cases. Actually, my case, 17 years old male patients with incontinence. These patients have a spina bifida at the newborn, had meningomular cell, and the brain surgeon closed the meningomular cell at the newborn. And patients have now urinary incontinence, fecal incontinence, no incontinence surgery or bladder surgery were done. No comorbidity, a little bit obese patients, body mass index is 29. Patients can walk, not dependent on wheelchair, slightly subnormal intelligence. When you ask the patients to cough, you can see the stress test is positive. He can void with Valsalva or straining. As you can see, there are some skin folds here. As you know, in spina bifida patients and surgery incision scar, you can see here around the sacral area. In spina bifida occulta, you can see also some screen folds, and also you can some hair production at the sacral area. There is no pediatric surgeon saw the patients at the time of the admitted at our clinic. And the initial test, do you have any suggestion for initial test or laboratory? I can take your suggestion, students. Okay, there's no suggestion. We can also start a urine culture and urinary test, urine test. No symptoms, no fever, no recurrent urinary tract infection in patient's history. Ultrasonography relevant, the bilateral kidneys is normal. There is no hydronephrosis, and creatinine level is also normal. Blood pressure is also normal, and there was a little bit higher post residual volume, almost 100 ml, and Qmax is almost 10 ml per second. And we did renal scintigraphy. Is right kidney is almost 45%, and left kidney is 55%, and there is no renal scar is reported. In the clinical settings, we check the bulbocorneosus reflex. The patients have a little bit atonic anus, and also there is no bulbocorneosus reflex. As you know, bulbocorneosus reflex can reflect the pelvic nerve integrity. What should we do after the next step? Simple urodynamic study with video. Do you want to start with antimuscarinic treatment or beta-3 agonist or pelvic floor muscle training. We can proceed to the urodynamics with video. We can call it the video urodynamics because in neurogenic patients with high risk, we can consider the high risk MS patients and also spinal cord injury. Actually, spinal cord injury patients and also spina bifida, we can consider the high risk patients, and we should recommend as a gold standard video urodynamics. Abhinav and Dr. Ruth, can you see my video urodynamic trace now?
No, sir. We can see the slide, but it
Yes,
was not
we can see also
video.
urodynamics. I can see
Okay,
the urodynamic trace.
Can you see now? Can you see my slides now?
Yeah, we can see.
Okay, I can continue. As you can see, there is a this is a abdominal pressure, and this is a here the red line is abdominal pressure, the green line is reflected intravesical pressure, and we have to detusor pressure here, the third line at the third line. When we start the feeling, as you can see, I can.
Yeah, we can see.
Yes, I can show with a pointer. You can see the gradually increasing in the vesical pressure, and also you can see the gradually increase in the detusor pressure here. This increasement is also just, we can call the rectal contraction and reflect a negative contraction as a detusor pressure. But we can easily say that this pressure, this bladder has a low compliant pressure. That means there is no higher urine without lower pressure. And we can detect the abdominal leak pressure is a lowest. That means patients can easily leak urine with any abdominal little bit straining, we can say. And we detect vesico-urotellar reflex at the right side, as you can see here, and the bladder shape is almost good, but with the bladder increase volume, as you can see, you can see the high grade reflux here. Bladder neck is also open here.
Professor Kadir?
Yes.
There is one question in the chat.
Of course, I can.
I think it is of previous slide.
Okay.
I can repeat the question.
Someone write the question?
Yeah,
Yes.
I can speak it. Is it leaking?
Okay. Actually, this leakage can depend the higher pressure and also bladder neck insufficiency. That's the stress urinary incontinence. If patients have not bladder neck insufficiency, patients can leak with higher pressure of the bladder, but this patients is spina bifida. Most of this kind of patients have also have bladder neck insufficiency. That means leak with a little bit straining. And also these patients have also low bladder compliance, and that means the low bladder capacity and low bladder compliance. We calculate the bladder compliance here almost 10, but it is so lower bladder compliance. And renal scintigraphy, we told that. And then we have several options such as antimuscarinics, beta-3 agonist, pelvic floor muscle training, and botulinum toxin injection and augmentation. We proceed to the treatment step by step in patients with neurogenic lower urinary tract dysfunction. We start with propivarin, that's the antimuscarinic receptor antagonist, block the antimuscarinic receptors on the bladder and try to increase bladder capacity and try to decrease detrusor pressures. But after this medication, patients has no improvements, also has a stress urinary incontinence. The next step will be intravesical botulinum toxin injection. If patients with detrusor overactivity or lower bladder compliance, we can start with medication. After the failed medication, we can proceed to the botulinum toxin injection with several formulation, onabotulinum toxin or abobotulinum toxin. In these patients, we did 200 unit intravesical botulinum toxin. As you know, botulinum toxin can inhibit the exocytosis of the presynaptic area, the exocytosis of the vesicles, which is containing the acetylcholine and another neurotransmitters, to the exocytosis of the presynaptic area, and that means block the neuromuscular junction, and bladder cannot contract as well. But there is no improvement in incontinence clinic. Actually, botulinum toxin can work in patients with detrusor overactivity. These patients have lower bladder compliance or fibrotic bladder. You can call it the fibrotic bladder. Botulinum toxin cannot work very well in fibrotic bladder when compared to detrusor overactivity bladder. Patients still use the PET and don't want to use clean intermittent catheterization. As a review article or meta-analysis, incontinence can improve almost 63%, and capacity is also increased almost 90% after the botulinum toxin injection in patients with neurogenic lower urinary tract dysfunction. And the detrusor pressure is going down after the botulinum toxin injection. There is no improvement in incontinence, still use PED and still has stress incontinence, because we don't expect the relieve their incontinence episodes, because we just do botulinum toxin onto the bladder. Patients has also, we know that patients still have bladder neck insufficiency and can't leak very easily. This is the second urodynamic studies. As you can see, after the botulinum toxin injection, there is no improvement on the bladder compliance. As you can see, there is a gradually increase on the vesical pressure and detrusor pressure. That means we also have also still low compliant bladder after botulinum toxin injection, and we have also lower abdominal leak point pressure. That means patients can still easily leak after the increase a little bit abdominal pressure. We have also right vesico-ureteral reflex here. Yeah, we failed these patients. We failed the medical treatment as an antimuscarinic treatment, and then we failed the 200 botulinum toxin injection, and then we have to go to the next step. It should be another process. Yes, this is Dr. Helmut Maders-Behart classification in European Association of Urology guidelines. We actually, in patients with lower urinary tract dysfunction, we have 4 scenarios. 2 of them is related to the bladder, and another 2 is related to the sphincter. Bladder can also work as a normal. Sphincter is also work as a normal. But in neurogenic lower urinary tract dysfunction, bladder can work over contraction as a over contraction or lower compliance, or bladder should be atonic, or bladder can't contract their self. These are two scenarios regarding to the bladder. We have also same scenario for the bladder neck or sphincter. The sphincter could be atonic. We have a patient, as you know, Spina Bifida occulta, and there's a bladder neck insufficiency. That means the sphincter is not contracted very well in order to block urinary leakage. Another last scenario is related to sphincter is not relaxed very well in order to permission to voiding. We will, after before the surgery, we have to check all of the status of the bladder neck, and also patient's ability to doing CIC through the native urethra or more higher levels from the abdomen. In these patients, we do augmentation cystoplasty. That means we increase the bladder capacity and we decrease the bladder compliance with augmentation to bladder with ileal segments. When we create ileal segments as a hemispheric and we put on the bladder the augmented ileum, and we can increase the bladder capacity, and also we can increase the bladder compliance. That means bladder can have more higher volume urine with lower pressure. And also we do a bladder neck sealing. That means we put the fascial sealing, rectus fascial sealing. We put the sealing as a 1 and 8 centimeter abdominal rectus fascia, and we put at the bladder neck as a sealing in order to increase bladder neck pressure. And also we do a tube from abdomen in order to doing clean intermittent catheterization through the augmented bladder, because especially in patients with wheelchair, but this patient is not dependent on wheelchair, patients can have some difficulties to reach their native urethra, especially the women patients with wheelchair is can so difficult to reach their native urethra, but we can put the stoma here, just the maybe up to the level of the umbilical level, and patients can easily do herself or himself catheterization to do in order to evacuate the urine from their bladder. We can increase bladder compliance almost 2 or 3 folds, and we can also increase the bladder capacity approximately 200 to 700 ml. We have several recommendations from our associations, such as European guidelines or American guidelines, and also ICS guidelines. Continence cutaneous diversion we can call the Mitrofanov, Monti, or Casale techniques. We can put the appendix between skin and bladder, and sometimes we put the ileal segments between skin and bladder in order to create a conduit for catheterization. And we can use the sling on both male and female patients. In also neurogenic patients, several reports can demonstrate that up to 100% of the patients can cure after sling surgery. After the postoperative 6 months, patients don't want to CIC. He has also want to do Valsalva avoiding urinary ultrasonography relevant that there is no hydronephrosis and post-voiding residual volume is also 100 CS. But patients is still stress urinary incontinence. That means sling is not working very well. We have also still continuing the bladder neck insufficiency, even we put the sling over there. After these treatments, there is another options for neurogenic stress urinary incontinence. We can put the artificial urinary sphincter. That means there is a cuff around the urethra. We can put to the cuff around to the urethra with an operation, and we put a pump in the scrotum or labia majora, and also we put a reservoir at the residue space just anterior of the bladder, native or bladder or augmented bladder. This reservoir can have almost 70 centimeter water pressure and reflex to the cuff around the urethra, and this pump can contract the urethra and block to the urinary leakage. We put to the artificial urinary sphincter in these patients, but after several months later, the urethral the tube erosion wasn't. As a normally, if there is an erosion after the artificial urinary sphincter implantation, if you can see any part of the prosthesis, you have to remove all parts of the prosthesis from the patients. And we also see a urethral erosion. That means cuff eroded the urethra, and you can see the Foley catheter urethra after perineal incision here. We remove all of the part of the artificial urinary sphincter from the patients. And we tied the urethra, that means we do urethroplasty after just removal from the artificial urinary sphincter. In patients with wheelchair, as you know, this case is not dependent on wheelchair. We can put the membranous urethra because our patient is not dependent on wheelchair. If patients is wheelchair dependent patients, if you want to put the membranous urethra, patient during the sitting position, the cuff compression of the urethra can easily cause the urethral erosion when compared to the wheelchair non-dependent patients. So the guidelines and authors can recommend put the artificial urinary sphincter at the bladder neck in wheelchair dependent patients. After 5 years later, we put to the second artificial urinary sphincter with another approach. We can call it the transcorporeal approach. We can put to the sphincter around to the urethra, but transcorporeally. We can cut the corpus cavernosum, as you can see here, and put to the cuff with corpus cavernosa. Yes, in male patients, artificial urinary sphincter is a gold standard regarding to the guidelines, and sling surgery is the gold standard for neurogenic urinary stress urinary incontinence in female patients. Yes, we can go to the reflex. If neurogenic bladder patients or neurogenic lower urinary tract dysfunction patients have a reflex, lower grade reflux, such as a 1 or 2. After the augmentation cystoplasty, the reflux can resolve itself. But if the patients have higher level of the vesicular reflex, such as a 4, you should or you can do the urothoracea cystostomy during the augmentation cystoplasty. In this video, you can see artificial urinary sphincter. How can artificial urinary sphincter works? This is a bladder here. We did cystoscopy. You can see the cystoscopy here now. Yes, we pushed the back to the cystoscopy through to the urethra. This is a membranous urethra here. As you can see, there is a circular sphincter cuff here. Is closing now. Yes, this is a closing cuff here. And then we go to the bladder again. And as you can see, the artificial urinary sphincter cuff is closing itself. Now it is closed. Okay. This is our patient's Spina Bifida. After the pumping, the scrotal pump, urethral cuff is open after the pumping of the artificial urinary sphincter, and patients can void with Valsalva maneuver. That means straining. And another video. As you can see, there is no leakage during the coughing. That's also good. Continence is, in these patients, continence is not 100%. We should call the social acceptable continence we aimed. That means some drop of the urine came out, but no need for use PET. We can also agree with this kind of patient, this kind of continence. Yes, Ruth, my second case is related to MS, but we discuss also MS patients. This is Spina Bifida patients. I can finish my presentation now. Yes, what is your thoughts on medication of loss compliance? Yes, I talk about the reflex. If the patients have high-grade reflex, we can repair with urothoracea cystostomy during the augmentation.
No, Kadir, I think the question is rather, if you have such a low compliance bladder in a spina bifida and you see already a reflux, would you start with antimuscarinics or would you go right straight to Botox?
Actually, at first, I start with first-line treatment, such as antimuscarinic, and then if the reflex is consist or the patient's complaints is consist, I proceed to do Botox, botulinum toxin injection, and then I can proceed to do augmentation cystoplasty. Yes, we have some dose escalation. In patients with neurogenic lower urinary tract dysfunction, the 200 unit is a now standard unit for botulinum toxin injection, but we can escalate to 300 units. But there is no more significant differences between 200 or more 300. There is actually no head-to-head comparison 200 or 300 botulinum toxin injection. But we can escalate. Actually, dose escalation in my patients without non-neurogenic urge incontinence. Sometimes, especially young patients with urge urinary incontinence, I did 100-unit botulinum toxin injection, and patients doesn't relieve very well. I can proceed to the dose escalation, such as 200 or 300 in also non-neurogenic patients. There is no, it's actually unpublished data, but we published as a abstract some congress. Another questions?
Anyone
Yes,
have more questions?
leakage. Yes, the leakage probably saved his kidney. Exactly, very good common in this kind of patients has fortunately incontinence, because these patients have also low bladder compliance. If you imagine that if this kind of patients with low bladder compliance can the continence or hold their urine inside, the kidneys is start to hydronephrosis due to the higher pressure of the bladder.
I think that was a fantastic pictures and great presentation. Thanks, and very brave to also target the incontinence. But you are right. First, we have to get a low pressure reservoir, and
yes.
augmentation is the last tool, but especially in young Spina Bifida patients, it is not so seldom that you don't succeed only with Botox, that you don't end in bladder augmentation. And of course, if the leakage prevents the kidney, the damage, it slows the renal damage definitely down, and so that's why she probably got 18 without significant kidney damage.
Yes, at first we have to say that our aim in patients with neurogenic lower urinary tract dysfunction, our aim is to prevent the upper urinary tract. That means the prevention of the renal insufficiency. So we have to repair or treat bladder capacity at first, and then we can treat the incontinence. Yes, there is a question: what is the upper limit of the detusor pressure in women after which you consider it to be high pressure? Actually, there is no cutoff point for detusor pressure. We can choose our treatments with compliance, actually, and patients' complaints.
Prof, there is a question in downstairs. Means you are reading up questions, but there is a question in downs.
Okay.
Can you?
What's your thoughts about
yes.
Botox into the sphincter?
Yes, Botox to sphincter. Actually, we have done several times the Botox into the bladder sphincter. There is a meta-analysis. Botox on the sphincter actually is work very well in patients with neurogenic lower urinary tract dysfunction, especially in suprasacral lesion, spinal cord injury with detrusor external sphincter dysynergy. After the botulinum toxin injection with on sphincter, the detrusor pressures is going down. The reflex is vesicular reflex is going down or relief, and also post residual urine volume is also decreased with increased pressure of the bladder outlet. So we can do botulinum toxin injection into the sphincter. Before the botulinum toxin injection, sphincterotomy was done. Actually, I have never done sphincterotomy. Ruth, have you ever experienced with sphincterotomy before?
No, because it's I think if you listen to the older neuro-urologists who have more experience, I have no experience with it. They think for some patients with an upper motor neural lesion and who of course rather prefer to use a condom urinal, because if you do also Botox in the sphincter, you risk incontinence, and we rather prefer a low pressure bladder and continence. So but the patients who can't do intermittent catheterization and want a solution, not depending on a catheter, it might be a solution, but there are rare cases. And I'm also a little bit afraid of doing a sphincterotomy. First of all, it has to be repeated often. It's a scarring. You have to really observe them also urodynamically, because it's not you do it once and you do it for a lifetime, but it can be a solution for patients who can't do intermittent catheterization and accept incontinence, and they have a proven low pressures in the bladder.
Yes, exactly. Nowadays, we did a chemical denervation as a botulinum toxin instead of
some can, if you then do urodynamically supervise, some of them with the upper motor lesion neuron can do a triggered avoiding, but we never allow them to do straining or using abdominal pressure to empty their bladder. And the triggering we only allow if we have proven that in urodynamics that they don't cause too high pressures.
Yeah, exactly. There's a question here. What is the role of Botox injection in case of high-grade incontinence with no detrusor overactivity? Actually, we talk about this, but we can say that actually, I have one slide here. I can show you quickly. What's going on after the botulinum toxin injection?
So, but I mean, if you have no detrusor activity proven,
yes, that means low bladder compliance. Botulinum toxin is not work very well because detrusor because the botulinum toxin is working act prevent the neuromuscular blockage in work for a contraction, inhibit the contraction of the bladder. If patient's bladder is not compliant, that means a low compliant bladder, the botulinum toxin is not working very well. That means yes, we can say that in randomized phase 3 clinical trials, the botulinum toxin can increase the bladder compliance, but when we subdivided the patients, we can say that in low compliant bladder, botulinum toxin is not working very well. Not really increase the bladder capacity. I can't find.
I think there are no. I think there are no more questions. Abhinav, do you see questions?
No, I think that's all. Anyone have more question to any professor or to share some of their own experience?
Okay, I want to take you. First of all, I want to take you, Dr. Ruth and Abhinav, and to Medsynergy, to collaboration our INUS, and Ukrainian students and give us an opportunity for today. Thank you so much.
Oh no, we would thank you to both of you.
And I think you should ask again for everybody who can put their pictures on that. We see some,
Yeah.
you know, because Kadir, you will be astonished how, you know, how diverse our audience is. I'm so glad to see so many young people. You see people from all over the world, not only Ukraine, and that is always a very nice picture. And I know Abhinav likes to take a screenshot of that.
Yeah, they were opening. So please open your cameras. Yeah.
And wave. And thanks, Kadir. I think you had a great case.
Thank you for joining. Yeah.
Thank you for joining.
Have a cheese.
Cheese. Cheese. Okay.
Good.
Okay. Bye.
Thank you so much for attending this session. I hope you like it and really learn from the two great professors of this field of neuro-urology. Next lecture were very interesting by the Dr. Kadir only in the research. So it was very interesting for our new physician and new students also who wants to pursue the career in the urology or neurology or in both.
Yes, I'm very much looking forward to the next talk from Kadir, you know, focusing on research and what's going on, because I think that makes academic moves forwards, and it's always good to have different aspects and different ideas. And I found the questions this time remarkably good.
Yes, I hope I am waiting for the next session. Thank you for all.
So thank you, everyone. You will receive the link in few minutes. I will share that quiz link. I will share. Okay, have a good evening and all the best for the quiz.
Thanks.
Okay, have a good evening. Goodbye.